At last but not least, I want to introduce Chris Wells. Actually, he doesn't need an introduction, Chris. At the moment, he's a consultant in pain medicine in Liverpool, but he has a very long bio, and like I said in the beginning, please check on your app, and you can read all our biographies and CVs. So I will leave it with the introduction that you know him. He's the current president of the European Pain Federation, and before we exit this room, talks and what could be other strategies. So the title is very simple: Exit Strategies. Chris?
Yay! If you're interested in this subject and you want to give me your details, I'll try and get you an invite to that symposium. And all through the modest little bottle of drops which I see on my bedroom chimneypiece of this moment. Drops, you are a darling. If I love nothing else, person, he was not given laudanum for analgesia, he just took it for fun. Next slide, please. This guy, Robert, this is reported in the Daily Telegraph in the UK a couple of years ago. He was off work with pain from 2003 with abdominal pain, non-specified, just the patient you wouldn't put on an opioid, but he was put on slow-release morphine, and he managed to get up to 3,000 milligrams a day, okay, which would kill a lot of people. A nice guy, but very habituated, obviously, to his opioid with a major problem. And he knew it affected him. He didn't like it. His personality deteriorated if he missed it. He was sluggish when he was on it. He had to have Viagra for his sex life. If he forgot to take the dose, he got withdrawal very rapidly. Next slide, please. This is one of my favorite paintings by Picasso, Boy with Pipe. This was thought to be one of Picasso's young lovers. And we can get, oh yeah, there we go. We can get the light to work. He has, you can't see it in this picture, he has mydriatic eyes from his opioid, and he and Picasso were lovers back in 1905. And he was, again, he was a street boy who was taking opioids, whether he was addicted or whether he very well, like Wilkie Collins, and some people have a major problem like Robert, and we don't know about the boy. So what do we do for treatment? Well, treatment needs to be individualized for each patient and based on ongoing patient monitoring and assessment. And it needs to be done, next slide please. It needs to be done with these considerations. Any patient who is addicted to any drug, illicit or prescribed, it's a chronic brain disorder that can be treated effectively. There's not only opioids that do this, pregabalin and gabapentin do the same thing. Some of our antidepressants, ketamine. Many of the drugs we use affect mood and behavior. So for opioid analgesic dependent patients no longer in pain, or recreational opioid analgesic users like Wilkie Collins and the boy, treatment should focus on addressing their dependence because they don't have any pain. And we need to look at the biopsychosocial approach as ever. Treatment needs to be to take into account the type of drug used and the need of the individual. If they have pain, then the treatment has to address that as well. So they've then got two chronic conditions. They've got chronic pain and they've got a chronic behavioral drug problem. Treatment involves the pain specialist, the primary care physician, possibly a psychologist, or hopefully a psychologist or counselor, occupational therapist, and other providers of health care. And indeed, it worked. Good. I did that. Okay, right. And we need to set goals and have planned treatment. Goals include avoiding harmful use of substances, achieving physical, psychological, and spiritual well-being, and goals in treating the pain and reducing the pain and associated symptoms, anxiety and depression, and enhancing their function and returning them to high-quality life. These goals are entirely compatible. We just need to plan carefully. We need to bring in the family. We need to bring in other carers. We need to talk with a GP and a social worker. And we need to identify the goals and the treatment plans. We need to make a plan. We need to document the plan with the patient and the family so that we can see how we're going along in practice. And if we can get our next one on, great, thank you. It's better together. Primary care physicians, pain specialists, and addiction specialists all need to work together. Next slide, please. To find the best solution for the shared individual patient. Next slide, please. This is some little pots with hemp in. That's a lovely sticky substance which Wilkie Collins was smoking. I'll show you some other pictures of what he used to do. Next slide, please. Treatment goals and treatment plans, the 5 A's. We need to negotiate with the patient and document these goals and targets in reporting on each of these structures. So A is for analgesia. Next slide, please. The next A is for activity. Next slide, please. The next slide, please, is for affect or mood. Next slide, please. Adverse events need to be taken into consideration. You've already heard about those from Bart. Next slide, please. And aberrant behaviors. So those are the 5 A's. You always refer to those in your management of these patients. Next slide, please. Identify how you're going to assess them and monitor them. You may do that with a patient doing self-monitoring and diaries. You may have to use assessment scales. You may monitor aberrant behavior with pill counts and urine drug screens, prescription monitoring systems. These are much more familiar to those of us who worked in North America, and much less familiar to us here in Europe. And we have Doug Gourlay, who's a very good friend of mine, who's speaking in Liverpool in the end of this month. And Doug and I first clashed in a very nice way many, many years ago when he was talking about urine testing. And I said, we don't have a problem in the UK with aberrant drug behaviors. He looked at me and he said, Chris, how do you know if you don't test their urine? You don't know if they're taking the drug. You don't know if they're selling it. You don't know if they're taking more. You don't know if they're taking other things. Anyway, he was kind of right. So yes, I listen to him a lot now. Next slide, please. So, on the one hand, we have the addiction treatment. On the other hand, we have the chronic pain. And this is the way we go through with everything. Behavioral management of the addiction, teaching them to function without drugs and deal with the cravings and the relapse. Improving their personal relationships and social functioning, which is often very poor. From the pain point of view, CBT, we know drugs themselves. From the addiction point of view, we can use pharmacological treatments to minimize the symptoms of withdrawal and cravings. And from the analgesic point of view, we can use drugs singly or in combination to help the pain that these patients will get. And we can also use physical treatments, including exercise, posture, and gait correction. Next slide, please. Because we know that increased physical activity is good for these patients and the pain gets worse. Next slide. So there we got some nice Wilkie Collins smoking hemp and some nice breathing in of these wonderful fumes. Next slide. So what are the pharmacological treatments? Well, there's 2 ways of doing this. We can go into a slower maintenance treatment with conventional analgesics or with buprenorphine or methadone, which are 2 weaning drugs. Or we can go for the detox route, which is more rapid. Pros of the former are there's a strong evidence of capacity to reduce opioid use, decrease mortality and morbidity, improve quality of life, and it avoids withdrawal in people who might be ill or unstable. Capacity to retain patients within treatment, and there's widespread availability. Against that, it's expensive in time and money. Patients have to attend surgery on a regular basis to get their drugs because we can't let them out with days and days of medication. There's side effects, stigma, more from methadone than buprenorphine, and the restriction of their lifestyle because they keep having to go to get their treatment, and even in many cases they have to be watched taking their drugs. Versus detox, which is much more short-term, therefore more attractive to the patient, a lower threshold, easier access, a good entry point, can be more beneficial for pain patients with opioid-associated aberrant behavior. Keeps stabilization of other health conditions, including chronic pain itself, which gets a lot worse, and mental health in a significant number. Next slide, please. So the non-opioid treatments, or you've already heard about the risks of those, and I quite agree, but I'm just going listing them. NSAIDs, tricyclics, anti-epileptics, which can themselves be, of course, addictive. Topicals, which would be good if they helped. TENS, which would be good if it helps. Cannabinoids have been touted. I'm very much against that because you're introducing another addictive drug with its own significant side effect profile. So I'm totally against giving these patients cannabinoids. Next slide, please. So there on the left side you have the detox, and on the right side you have the maintenance. The detox could be gradual or abrupt. Detox treatments has been used over many decades and may be suitable for a significant number of patients as part of their plan. All detox patient approaches, however, are only partially effective in controlling the symptoms of withdrawal, so they're still going to get some symptoms anyway, and they need to understand that, and they're associated with a high relapse rate. Maintenance, if there's no history of significant aberrant behaviors, you can consider a trial of conventional opioid analgesic, perhaps in reduced dosage. Morphine, oxycodone, fentanyl. Personally, I like tapentadol, sustained release. I think it has significantly less side effects than other opioids. And that's the one I tend to use to try and get these patients on if I'm not going to the buprenorphine route. And they need frequent review and they need frequent monitoring, and we find that difficult to do in pain clinics, so the GP has to be involved, or if you've got a good addiction clinic, that's great. In the UK, we've got two types of addiction clinic. We've got the ones that really like these patients because they're not street addicts, they're quite clean. We've actually got another addiction clinic that doesn't like them because they want to work with street addicts and they want to work with those heroin and the junkies, and they don't like these patients. They feel these patients are privileged and they don't need the support. So we've got units that we like and we work with very successfully, and we've got units that we can't get on with. So if the patient's unlikely to adhere to a treatment plan or has a significant aberrant behaviors, then we need to look at the buprenorphine or methadone usage. And there's evidence which exists to support its use in the treatment of opioid analgesic dependence. They both have analgesic effects, of course. Next slide. In either case, psychosocial services have to be made available, although some patients will not take up these offers, and that doesn't mean that we should deny them effective pharmacological treatments. It's just that the chances of success are much higher if they do take up that option. Next slide. Detox. Australian guidelines make it very clear exactly what we should be doing and the different types of approach. We can have the abrupt cessation with amelioration with non-opioid drugs, or we can go for the short course over about a month of reducing doses of buprenorphine. Detoxification can be achieved by tapering the opioid that the patient's been on, or switching to a different long-term opioid and then tapering. Tapering may benefit patients with severe chronic non-cancer pain despite them having been on opioids for a long time. And actually, they seem less likely to relapse than non-pain opioid-dependent patients. So that's why you'd think that the addiction clinics would quite like them. And it can get good benefit in the long term without any apparent severe pain. Next slide. What do? We talked about the plan. We need to structure routine appointments on a regular basis. We need to look at supervised dosing, where they come in and they're observed to take their medication. We need regular patient review with the 5 A's, psychosocial report, I've mentioned already, in the family and peer engagement. That's just to recap. Next slide. Opium den with a nice pipe. Next slide. Buprenorphine versus methadone. Buprenorphine has a superior safety profile than methadone. It blocks the action of some other opioids that may be provided for pain. Some patients report greater clarity on it, and in that way it may be better. Both buprenorphine and methadone, with or without, the buprenorphine with or without naloxone, can produce hyperalgesia. There's some evidence that buprenorphine produces less, but it's not great. Methadone has a stronger opioid action and is associated with greater retention in treatment because of that action. But the longer term side effects are more common. The impact on sex hormones, the sleep apnea, prolonged QT interval you've already heard about, and they're more likely to get drug interactions. Next slide, please. And again. Transfer, what do we do? Patients who we want to put on buprenorphine, we start them with buprenorphine naloxone, which is the abuse deterrent formulation. We don't give them that until they start to get withdrawals. So we reduce their medication, wait till they get withdrawal, and then we give the buprenorphine, which displaces the full agonists, but has a lower activity as its partial agonist. So it can cause a precipitated opioid withdrawal syndrome if given too soon after a recent dose of a full agonist. We have to wait. Next slide, please. It's not usually associated with that, as long as we hold off and wait for the withdrawal to start. And then once we add that in, it mitigates the withdrawal. We need to review them very regularly every day while the dose is stabilized. If they're getting a mild withdrawal, we might use 4 milligrams, a subsequent dose of another 4 milligrams after 1 or 2 hours. Moderate withdrawal, looking at 8 milligrams. Lower on certain levels of opioid dependence, we might go as small as 2 milligrams. Next slide. And we titrate up the dose over 2 to 3 days, adjusting it after regular review of the patient, assessing side effects, withdrawal, intoxication, cravings, and substance abuse. So this requires a lot of time and effort, which we don't have in some painkillers, well, many painkillers, most painkillers. GPs may be able to do it, or addiction specialists. Next slide. So the overview, it can involve a precipitated withdrawal, but that's not high. It can give us a problem if we are on long-acting opioids. We may think about switching to short-term, but that's not usually recommended. And we, again, here with these long-acting ones, we delay until there's clear evidence of withdrawal, and we look for strategies to manage risk factors for complications during transfer. We really want to get them so that they have the withdrawal mid-morning, or not 10 o'clock at night. Next slide. Some nice hemp wrapped in a banana wrap. Next slide. Transferring to methadone, similar sort of thing. We taper off the prescription medication by 25% every 5 to 7 days, and add in the methadone. Next slide. We increase the dose gradually to achieve cessation or reduction in the unsanctioned opioid use, alleviation of cravings between doses. We may need doses, big doses of methadone of 80 milligrams or more, which will remarkably reduce the effect of any ongoing opioid use and mitigate their pain. It depends on the dose that they're on, as the dose you're going to go up to in methadone. And in smaller doses, 100 milligrams, 8 milligrams is enough. In bigger doses, 400 milligrams, we're looking at an eighth of the dose, 25 milligrams. And in Brian, who was on 3,000, I'm glad I didn't have to get involved with him. I just read about it in the Daily Telegraph. Next slide, please. Do not assume that the analgesic being prescribed is what's being taken. Patients may be taking more, or because they buy it, or save it, or less because they're selling it, or administering their medication by alternative methods. So that's why we really, ideally, have to see them swallowing it. Okay, be aware that the published equivalent opioid dosages relate to short-term rather than chronic opioid usage, and we just have to be prepared to vary it. Analgesic equivalents for single dosages have been described, but not necessarily for 24. We really have to determine it by trial and error, individualizing it for patients. And it requires a more structured environment than buprenorphine. Next slide, please. So, all doses of methadone should be supervised. We need to review the patient. We talked about the starting doses, about 20 milligrams, titrating up to about 40 to 60 after the end of week 2. Next slide, please. And the one after. In the maintenance phase, We have to observe them for maintenance. We have to consider their ongoing pain, their support, and we need to titrate the dosage to eliminate the withdrawal and cravings and the side effects. Psychological support, as we said. Next slide. A comprehensive clinical review gives us the opportunity to assess those 5 A's that we talked about before and document them. Next slide. And we know that this can be successful. We can detox them from opioid misuse. Benefits have been shown for long-term opioid medicated chronic pain patients. Sustained pain relief can be achieved and lower relapse rate than opioid addicted patients. However, on the downside, most people with opioid dependence relapse after detoxification. In a study of non-medicated detoxes, 27% of patients relapsed on the day of discharge, 65% within a month, and 90% within a year of discharge. So we can succeed, but it may well be short term. We just have to pick them up, dust them down, start them all over again. Next slide, please. As for Robert, he said he felt locked into taking his pills, even though he insisted he never got a buzz or a high from morphine ever. In the end, he came off his medication in hospital. He had buprenorphine, which helped, and a lot of support, which helped, but it was still extremely unpleasant. Now I take a milder painkiller, he says, and I suffer. My choice is morphine or pain. The pain is a sobering thing. Next slide, please. That's the drug dealer weighing out the morphine for the addict before him. And of course, it's a balance of side effects versus effect. I'm delighted to see so many of you here. Thanks very much for coming to this symposium. Thanks for listening. I welcome you to the welcoming opening ceremony. Thank you very much.